Hi, this is Yazan Daaboul, live from ACC 2023, and I'm pleased to be joined by Drs. Jiang and Dr. Serge Korjian. Thank you both for joining us.
Thank you so much for having us, Yaz. I'm excited to be here today.
Same here.
So let's do the ACC summary, the wrap-up. Serge, hit us with what's hot and exciting at ACC.
So on my end, I'm going to tell you a little bit about the structural studies that we saw at ACC 2023. Yesterday, we had the Triluminant Pivotal study. It was basically 350 patients that were randomized one-to-one to either tricuspid repair versus medical therapy. These patients basically were on optimal medical therapy from a heart failure standpoint. They had elevated risk for surgery, so they were unable to undergo surgery. And what we saw is that the clip works. There was a 90% reduction in tricuspid regurgitation from severe torrential to at least moderate, which was good. The trial hit its primary endpoint, which was a composite of three major things: death or tricuspid valve surgery, heart failure hospitalization, and KCCQ score. So I think the issue that people brought up with this study is that the study wasn't blinded. Obviously, you're doing a intervention on patients, so they're going to know when they've gotten the clip versus when they haven't. And the way the study met its primary endpoint is mostly driven by the KCCQ. So there's some people who, rightfully say that this might be a little biased. There's a little bit of a Hawthorne effect happening here, where patients are a little bit aware of that intervention and might change their responses to the KCCQ. But again, some exciting data about tricuspid repair from a transcatheter standpoint. We have the 5-year results for COAPT, very exciting. Continued reductions in, persistent reductions in heart failure hospitalizations and reductions in mortality. We saw in 2018 that there was almost a halving of heart failure hospitalizations, which still is seen 5 years out, and there's a reduction in mortality as well that is still maintained 5 years out. So again, I think MitraClip is going to be further used in patients with heart failure who continue to have and severe mitral regurgitation who continue to have symptoms despite optimal medical therapy. We also saw the results from the Evolute low-risk study, the 3-year results, which still show that the Evolute valve still performs really well. The adverse events are still comparable 3 years out as they were from the initial 1-year study. I'll say there are improved hemodynamics as well that were noted with the TAVR valve compared to the surgical valves. Again, additional data points for transcatheter valves as well. So very exciting.
Yeah, no, that is exciting in the structural world. Ginger, moving to you. Tell us more about the STOP-CA trial.
Absolutely, yeah. So one of the trials that I was most excited to hear about yesterday was in the cardio-oncology space, STOP-CA. And this trial sought to look at whether or not atorvastatin has any cardioprotective effect on anthracycline-related cardiotoxicity. And so it was a randomized placebo-controlled trial where they randomized 300 patients to atorvastatin versus placebo. And what they found was it was a positive trial, actually. There was a around threefold reduction in rate of LV decline in the patients who received atorvastatin. So this is extremely exciting. There were, of course, a couple of limitations to the study. There was only a 12-month follow-up, so it is unclear if the cardioprotective effects of atorvastatin will persist beyond 12 months. And then I did also want to just highlight that the trial enrolled 50% women, which is really notable. And so there's still a lot of work to be done to ensure that our trial enrollments are diverse and representative of our patient populations. But I think that was really exciting to highlight.
Yeah, I'm actually going to be sharing with you guys the results of the CLEAR Outcomes trial for bempedoic acid versus placebo in statin intolerant patients. So 14,000 patients were enrolled, all of whom were statin intolerant. And actually all these patients had to write very clearly in documentation that they are truly statin intolerant. They recognize the benefits of statin, but they were still not willing to take statin, most of whom are basically intolerant to the myopathy. So patients were randomized to either bempedoic acid versus placebo and then followed over time for the cardiovascular outcomes. The primary endpoint was 4 MACE outcomes, including death, heart failure, death, stroke, MI, and urgent revascularization. And there was a significant reduction with bempedoic acid versus placebo with an absolute risk reduction of 1.6%. Number needed to treat was 63. We also saw, which is more known information from before, very similar to prior bempedoic acid studies showing significant reduction in LDL, 22%, with also high sensitivity CRP. And also I want to echo, the findings from your trial from the STOP CA, also 50% of the patients enrolled in Clear Outcomes were also women, which of course is the patient population of basically extreme interest in statin intolerance, because most of these patients actually tend to be women. So this was a very representative trial. So very exciting. Ginger, what else do you have?
That's awesome. Well, one of the trials that I was really excited to hear about that just broke out today was the BioVasc trial, and this was in the interventional space. And so it's known, guidelines recommend now that any patient who presents with ACS in the absence of cardiogenic shock with multivessel disease benefits from complete revascularization. But what remains unknown is what is the optimal timing of the revascularization. And so what BioVasc did, it was a large randomized multi-center trial, and they randomized patients to either immediate complete revascularization or a staged complete revascularization. And it was a non-inferiority trial, first just to answer the question of, is immediate complete revascularization even something safe that we can do? And it was found to be non-inferior. And then interestingly, in the secondary analyses, there were fewer MIs and also fewer unplanned ischemia-driven revascularizations in the immediate complete revascularization arm compared to the staged complete revascularization arm. So it's going to be really interesting to see how this impacts our clinical practice in the cath lab.
Absolutely. Yeah, the last study I want to talk about is the UK mini mitral trial, which was a randomized control trial comparing minimally invasive thoracotomy versus standard sternotomy in patients with degenerative mitral regurgitation. The trial enrolled 1,300 patients to basically either arms, and the primary endpoint was physical function at 12 weeks. It was a non-inferiority trial as well, so the trial met its primary endpoint. There was basically no difference in physical function between both arms, and actually even when followed through 1 year, 52 weeks, there was still no change in physical function. Patients who did get the minimally invasive thoracotomy actually had better recovery, earlier discharge from hospital. So there was some signal for benefit in terms of not the primary endpoint of physical function, but in terms of recovery and in terms of being discharged and being home earlier. So super exciting trial findings. Thank you both for joining us. And thank you all for joining us live from ACC 2023.